viral forms of arthritis still need to be kept in mind. Generally speaking, these are self-limited, they are non-erosive and non-destructive, but they may catch us off guard, and we may misdiagnose these as the beginnings of chronic rheumatic diseases. Parvovirus B19 is a resurgence right now in the country, and in adults that can produce a self-limiting but quite impressive additive polyarthritis. It's just one example. We also like to think about arthritis in the returning traveler or people with rheumatic symptoms and after they've traveled. They come to see us. Yes, I was in South America last month, or I was traveling around the world, or I was somewhere. In infectious disease world, this is canonical. This epidemiologic history, not so much in rheumatology, but we can bring back conditions, everything from chikungunya and an arbovirus, member of the alpha virus class, which can do this, to things such as dengue, which is now endemic in certain states in the United States, and Zika and beyond, new pathogens. So we keep that in mind in our differential diagnosis. The second area is comorbid viral infections. This is really important. While hepatitis B and hepatitis C and HIV are what we refer to in ID as deaccelerating infections. We have treatments. We can cure hepatitis C, we can't cure hepatitis B, and we can't cure HIV, but we have suppressed it, and the actual infection rates are going down ever so slightly, but that's a really good thing. When we use biologics, we have everything from strong, bold letter warning to black box warning, such as the use of B-cell depleting agents and hepatitis B reactivation. So we need to understand that patients going on to immunosuppressive therapies with targeted therapies need to be screened for hepatitis C, hepatitis B, and in our rheumatology infectious disease clinic, we always make sure that patients have been screened for HIV. That means that we need to be able to interpret these sometimes complex serologies, particularly for hepatitis B, and have good working relationships with hepatologists or an ID doctor. And then finally, the practical aspects of comorbid, of beyond comorbid, but complications of viral infections that we may induce are really important. And I think zoster is probably the most important because of the scope of it. Zoster is a common disease. It can be quite serious. There can be severe complications, including stroke and even dissemination and fatality. While we think of zoster as being a function of age, as it increases in incidences as we age and our immune systems undergo immunosenescence, our therapies can dramatically increase the incidence of this and make people vulnerable. Glucocorticoid therapy is a great example, particularly chronic and moderate to higher doses. But in the era of biologics and targeted therapies, we go far beyond that. And we now have a whole class of drugs, the JAK inhibitors, that are zoster machines. And we've written recently about this, about the challenges of preventing zoster in the compromised host. So strategies and being, well-versed on immunization practices and how to do this, seamlessly is really important. Other infections also can be induced or reactivated by our therapies.